So at this point, I'd like to introduce our first speaker, Kim. And Kim has been here before. She's a regular at our meetings sometimes, and she is from hospice care of Boulder and Broomfield County. The first thing I ought to tell you about her is what's most important in her life. Got to get the important things out first. And that's her dog. She has a dog, and the dog's name is Coyote. And she assures me that the dog is smarter than she is. So I just want you to know that. I'm wondering why we didn't invite the dog here. Kim has worked at hospice care of Boulder and Broomfield counties for the last 19 years. She started out directing the family and community grief services and is now a director of community education. She has developed and facilitated educational offerings, professional trainings, grief support, and critical incident debriefing services for many different groups. Kim has been a keynote speaker, a published author, a national presenter, and is on the board of directors of the Association of Death Education and Counseling. So would you please join me in greeting Kim.
Well, now I have to open by saying, woof! And also happy St. Patrick's Day to everybody. I'm really lucky to have two incredible docs with me. Okay, closer? Okay, thank you. Remind me if this moves away. Okay, so the reason we wanted to do this is because, as we know, there's just lots of gaps in communication. And let me start out with a couple of thoughts. If you have a handout, if you don't have a handout, would you share with the person next to you? Because Dr. Sitarik is going to reference that when he gets up to talk. Yeah, pass them around. Thanks. So one of the things we never know is when someone changes from a very healthy situation into one where they're going to end up dying. We're all going to end up dying. One of the things we like to say in the field is that life is a sexually transmitted disease that ends in death. We just are not sure when that trajectory starts. Yes?
Could we turn it up? My mother can't hear me.
Okay.
Can we turn up the volume? Is that awesome?
Or I can leave it. Can you hear me now?
Yeah.
Okay. Okay.
Speak more into it.
Okay. Clearly, okay, got it. So do I have to tell my dirty joke again? One more thing I have that's kind of cautionary is that I know that when people get in a room like this, some of us will have had unfortunate or frightening or confusing experiences talking to physicians. And that dialogue back and forth can be very difficult. So usually there are one or two people who've had what I would call a horror story. And we don't have time today to go into those. I think people really need to have a place to express their feelings and talk about them. That's not what we're doing today. So if you have a question that's come out of a medical situation that you have, please feel free to ask it. But in the interest of time, I think we're going to have a lot of dialogue. So just hold the stories just a little bit. Anyway, what we're talking today, again, is about that continuum of health, the part where we're not really clear what's happening, but clearly our health is failing. And how you do that, how you learn how to do that is to start now. You start changing your relationship to your own medicine now. And what used to happen years ago is we had very paternalistic doctors, and we did whatever they told us to do. And we kind of swung now to where oftentimes the doctor will give you a menu, but you don't really understand what it means. So the point of this is really to help people discern the best by using their relationship with their physician and their medical team. What are their choices, and how do they know how to make them? And I think a lot of docs are confused about how to do that, as are our patients. Luckily, the two people that we have here today, Dr. Myrle Miller and Dr. Mark Sitarik, are experts at this. They are fantastic. So I'm going to turn it over to them. They're going to spend a little time, like 5 minutes, just introducing themselves and kind of setting the stage. It's going to come back to me. I'm going to ask a couple of questions just so we can really get a broad sense of what they know. Neither one of them will say woof. And then we'll open it up. Does that sound good to people? Okay. Thank you. So, yeah.
Great. Thanks. Thanks a lot, Kim. Yeah, perhaps, first I'll just start with who I am in case I see some familiar faces here, but not everybody knows who I am. So basically, I'm a medical oncologist. I'm a medical oncologist. I've been practicing in town here for 25 years, and I'm part of Rocky Mountain Cancer Centers. I also have a very significant interest in medical informatics and how decisions are made, and being able to present information not only to patients but also to healthcare providers so that they can help make appropriate decisions in a real-time kind of a way. So what I'd actually like to do before we get into the meat of the day here is talk a little bit about the handout that I made for you here. And as you can see, these are basically the old bell-shaped curve that we're all familiar with from getting graded on a curve in high school or whatever. And basically, there's two curves there that are always interacting when you're trying to make a medical decision. The first, the green one, is an idea of what the probability of a good outcome might be for any given disease state or intervention. And the red one is the probability that something bad will happen because of that intervention. And there's always those two curves in whatever decision you make. And the top one is basically something where there's very little interaction between the two curves. They're never completely separate, but the top one is where there's very little interaction. So that's things like adjuvant breast cancer treatment in the oncology world, or treatment of pneumonia, for instance, where you give an antibiotic and most of the time people do great, but some people have a life-threatening allergic reaction, for instance. That doesn't mean that because 0.1% of people have a life-threatening allergic reaction that you don't treat everybody else. So so that's an example where the curves are really very, very separate. As the disease processes get more serious, and as the treatments become less effective, you kind of have the middle curve there, and that's where the majority of folks have some benefit, but there's substantial risks associated with therapy. And then the bottom part is where the curves are almost superimposable, so that there's a few people who do okay and do well. The vast majority of people don't. And really, when you make medical decisions, part of the issue is trying to figure out where those curves are and how close they are together. And unfortunately, this isn't something you can really get from the internet. This is where the experience of your healthcare provider comes in, because all kinds of things affect how close those curves are together. Things like age, underlying health, what the underlying condition is, what previous treatments have been, all that goes into the mix. Also, something that goes into the mix is what are your goals? What are you trying to accomplish? And unless you can really have that clearly in mind, it's really easy to make a recommendation that is not appropriate for the individual, especially when there's a lot of gray area. So anyway, so that's an explanation of the the graphs there, and it's just a good framework in which you can really think about how to make those decisions. So, any questions about that at this point?
Well, I'm curious about the probabilities in general and how they're obtained, but specifically pancreatic cancer, there isn't a stage here, so is that any stage?
Most pancreatic cancers that you... The question was, there's no stage associated with pancreatic cancer. Does this hold for all pancreatic cancers? And the answer is no, it doesn't, but it holds for the vast majority. And that's because most pancreatic cancers are diagnosed at an advanced stage, and 95% or more have a very terrible prognosis associated with them. So, so I think the way to look at the graphs here is not so much exactly what the examples were that I put underneath, but just kind of the general concepts about how the decisions are made and what the underlying probabilities might be. And I purposely left data off of these, because it varies so much with the individual situation that it's really kind of impossible to do that except on a very individualized case-by-case basis. So. Okay. Diane?
So what I'm understanding is that treatment is the yellow thing, right? Treatment with good intention is the yellow thing.
The yellow thing is what is the yellow thing was the question on the graph, and the answer to that is the yellow thing is the chance of something bad happening despite the good intentions of treatment. Okay, so the risk of a bad outcome, perhaps, if you want to look at it that way, or the risk of the therapy not working the way you expect it to. Maybe I'll give Myrle a chance here.
Good morning. Thanks for being here on a beautiful Saturday morning. My name is Myrle Miller, and I practiced emergency medicine for 22 years. And over the last 2 years, I have been working with Hospice Care of Boulder and Broomfield County, and basically retraining, reinventing myself as more of a palliative care physician. And when I thought about coming to talk to you this morning, I had a couple of thoughts, and some of this comes from actually a relatively recent experience of my own with a family member who required medical care. It's good for physicians sometimes to be in the other seat at times. I think part of what's hard about all this is that medicine is very complex today, and there's a lot of technology involved, and because of that it can be really intimidating. And I think it helps anytime you're sick or a family member's sick and you're interacting with the healthcare system, it helps to have an advocate. So someone with you there who can help you track the information that people may be trying, your healthcare providers may be giving you, and also track the questions you need to ask so that help with that information exchange. Docs are trained, have routines that they use with patients to get information about your symptoms and to understand what you're going through. Sometimes us as individuals aren't trained that well at how to get the information from the docs. So that's what a lot of this is about, I think. Other things to remember is that docs and hospitals are docs are trained and hospitals are constructed to offer treatment. So when you go there, you will be offered treatment. You may not realize that you have choices. It's not always presented in a way that makes you feel like you have choices, but you always have choices. And that's part of what we're talking about today. And I think in trying to make decisions, it helps to try to understand some of this stuff that the graph refers to. What is the likelihood? What are some of the outcomes that could happen, good or bad? What is the possible benefit of the treatment? What is the burden or side effects of the treatment? Because those are things that are going to be important to you to know. And quite frankly, hopefully, the decision-making can be driven by your own values. And I think that's really important. As you interact with docs, it's important for a doc or other healthcare provider to be able to get a sense of who you are, what your values are, how you've lived your life, how you want to spend the rest of your time, because that plays a role in whether you're going to want repeat hospitalizations or whatever treatment's being offered. What else was I going to say? One other thing that I think is important is if you think about when you interact with the healthcare system today, often you might be seeing multiple different docs. And I think that's part of the challenge too, because each person can give you an opinion about a different part of your healthcare. And part of the challenge is putting all of that together and getting a handle on the big picture. And the big picture, I mean sort of where you are on this trajectory of this sexually transmitted disease called life, headed towards death. Where are you on that trajectory, and are you losing some of your function? Are you getting closer to death? Because that's important in making these decisions too. And it's the kind of thing that the old, back when everybody, well, not everybody did, but if you had one family physician for most of your life, you might have had that kind of relationship where the physician would have a sense of you. And that is hard to come by these days because there's so many different doctors you interact with, and often it's a different doctor in the hospital than it is in a clinic. But it's also important as a patient or a family member to try to get a sense of that big picture and that trajectory. And I think that's all my thoughts for right now, but I'm hoping we have a good dialogue here with some questions and answers. Yes?
As you say, quite often for example, like with Kaiser, I have a primary care physician, but if I was on my way out, I'd be, for example, Good Samaritan, and being treated under a different rule, but also mostly by other doctors. So how am I to utilize the relationship that I have with my primary care doctor in terms of the communication that we should have had, or maybe we did have? How do I translate that over to the physicians that I'm being treated with, or to my trustee for my medical power of attorney?
I think there are a couple of, the question was, how do I transfer the relationship and discussions I've had with my own physician to the docs that take care of me when I'm in the hospital? And one of the answers there is the more that we have these conversations with our doctors and with our families, the better we get at them. And you will be, if you've had those conversations with your own doctor, you'll be better prepared to have those conversations in the hospital as well. Because you will have thought through things, you will have a sense of how you need to put it, what you need to communicate. So I think that's part of the answer to that. That's a challenging question. Kim?
So we're going to be passing the mic back and forth because I'm going to ask a question and then they're going to answer it. And after a couple of those, they're going to answer it brilliantly too. After a couple of questions, then we can just open it up to conversation. Okay. So the first one is, what is your ideal situation for talking to a patient about their failing health?
Yeah, this is actually it's really something I do on a very regular basis, and I think there's a couple of key components that go into this. One is there are actually different kinds of visits in the doctor's office, although to the patient it may seem like they're all the same kind of visit. They're really not. There are kind of maintenance visits where treatment's being undertaken, or we're looking for toxicity, or just kind of it's a relatively routine visit. And then there's something called decision visits they're really very distinctly different, and those are visits that occur when there is a new diagnosis or new diagnostic information coming to light, when we're evaluating to see whether a particular therapy is beneficial and should be continued or changed, or if we're having a conversation about the bottom graph here, where the risk-benefit ratio really just does not justify any kind of further therapy. So when we can identify those visits ahead of time in scheduling, we try to make them a little bit longer. because the last thing you want to do is try to have an in-depth conversation like this in like 12 and a half minutes or whatever, you know. So I mean, it's really just a disservice, and it's very unsatisfying. So we really try to have a little bit more time to really fully explore what the options are. I think if that kind of question is initiated by the patient on one of those kind of non-decision visits, then ideally somebody would ask for a little bit more time, you know, and not just a routine visit, and come in with 5 family members from out of town and say, "Doc, you know, I'd really like you to review, you know, the past 5 years of my medical history and like talk about what I'm going to do, you know, next." Okay, so because it's just not fair. So really having adequate amount of time is important. I think it's important also to have at least one other person there that can really act as a you know, the second set of eyes and ears that are with the patient, that can really kind of repeat things later. Maybe 2 people might be appropriate. 10 family members is not appropriate, okay? Because you really set up abnormal dynamics when that happens, and you really don't get the information out. So, you know, so 1 or 2 trusted friends, associates, family members, whatever, is really ideal. It's ideal to have the physician sit down. And not deliver this standing at the door with their hand on the doorknob, okay? All right, you know, so you got to pay attention to those kinds of things. It's important to make good eye contact because, you know, and you know, so making eye contact and not typing on the computer at the same time when you're talking about these kinds of things is really important. The other ideal situation for me is to really be able to show the patient the source data, and what that means is if there's a new finding on an X-ray, to really kind of, you know, the wonders of electronics is we can bring those up right in the exam room, and we can bring up the current images, we can bring up the previous images, we can see how things have changed, and by using multiple different ways to communicate information, it really makes the information much more real than just words. So I think that's important too, and it's important to get a range of options because there's never just one option for something. You know, there's always a no therapy option, and when you say no therapy, you also have to say, well, what does that look like, and what does that mean, and what do you think is going to happen in that kind of situation? There's a therapy option, or 2, or 3, or 4, and then it really is a disservice to just give the option and say, what do you want to do? You know, because that's what you get from the internet. You know, I mean, that's there's no way to really make an adequate informed judgment in that situation. So what I'll usually do at that point is make my best recommendation based on my knowledge of the patient, past history, what the disease process is, how many previous treatments they've had, and kind of where we are on this continuum of curve overlap, you know, which I find is a really kind of useful thing in my brain. So, you know, so for instance, you know, age is not as big a factor as you would think about deciding on whether treatment is appropriate or not. It's really about what your functional status is. So I have folks that are in their mid-80s with metastatic colon cancer that I'm treating with chemotherapy because they're skiing 50 days a year. Okay, so you know, you make a different decision for those folks, or a different recommendation, than someone who has been in a wheelchair for, you know, 5 years and is dependent on oxygen and is lucky if they can get up out of the chair to go to the bathroom. So because their chance of having a significant complication is so much higher than the other guys. So it's really very much a judgment call. And part of my job as a consultant is to give you my benefit of you know, the expertise that the experience that I've seen over the years with different kinds of folks in different kinds of situations. So anyway.
I should have said this earlier, but the reason I had Dr. Sitarik start is that we are really looking at the continuum of where those conversations may or may not happen. And people often think that the hospice referral is the last conversation that they're going to have. That once they've jumped off the cliff, there's nothing else to talk about. And I think that that's really different than what people expect, that we do admissions visits where we're creating the same kind of opening for people, but then the conversation continues, and the questions continue, and the guidance continues. And that's what we do, and that's some of what I wanted you to speak to as the continuum moves on. Did I just give you a trick question?
Well, first, just to respond a little bit to the first question you asked about the ideal circumstances for having these kinds of conversations. As you can imagine, I've had these in many different settings, and it's quite challenging in the emergency department when someone comes in critically ill with an acute change in their health to have this entire conversation. And I often had to do that just because people weren't thinking ahead, and because things surprise you. So that's a very challenging place to have this conversation. And I used to resent it in the ER and think, why haven't these people thought about this before now? Why is it up to me? And then I realized it was actually a real opportunity to talk to people and help people think things through. And now in hospice, when I meet with people, it's a very different setting because I'm able to dedicate significant time and space to be able to sit down with a person and the people that are important to them and try to talk through what's going on in their healthcare system and what they're facing and what their options are, and help them. A lot of it is just asking questions and letting people listen to themselves. Because if you can ask the right open-ended questions, then people can come to answers on their own. It's not like I'm necessarily telling anyone what to do. I'm more often asking questions. And then people are getting there on their own. Now, you had that follow-up trip question. Did I answer it or not? I guess it's interesting in hospice. Too often, one of the biggest complaints we hear is that people feel like they got involved too late. And we have this reputation of being just in the last hours of life. Whereas the people who are fortunate enough to get involved with us early on, I think can really benefit a lot from hospice services. And it's interesting when I go see them because we have to make a judgment based on Medicare rules about eligibility for hospice. And so sometimes when I go visit someone, they're worried that they're doing too well and they're going to graduate. So, I mean, there are a lot of different kinds of conversations that I wasn't necessarily expecting when I got involved. I would say one other thing, and I'm sort of leaning, you've got a clinic practice doc. Most of my experience was in the hospital, in the ER. And even now, a lot of the consults I do are palliative consults in the hospital. So I have that perspective. But now, one of the things that happens is sometimes I'll be called in to sit down with a patient and their family in the hospital and try to review what's going on, what they're hearing, put it together, what's being told by each of their specialists, and help them make decisions. And hospitals are developing what they call palliative services. Palliation basically should always be part of medicine. It just means relieving suffering, relieving symptoms. But the way it's being used in our healthcare system more often now is to help address symptoms, but also evaluate and make decisions. And so that's one person who can come in when you're in the hospital and your own doc's not around and try to put the pieces of the puzzle together with you.
Like what kind of decisions?
A lot of different kinds of decisions. Sometimes it's something like someone has a disease and it's no longer responding to treatment, and they have to decide if they're going to take the step of getting put on something like a ventilator or not. part of it is deciding, I think Kim's talked to you a little bit about the MOST form. Did you talk to them about the MOST form in the past? So that stands for Medical Orders for Scope of Treatment, and it addresses, it's something that people who have serious illnesses, it's very useful to look at because it looks at what your own values and goals and wishes would be regarding allowing a natural death to happen, as opposed to being someone who goes through CPR type process. It talks about whether you want, what your feelings are about medical interventions, whether you want to go through full treatment possibly for whatever happens, get put in the ICU, get connected to whatever support, life support you need, more limited interventions, or just comfort care. It talks about your wishes regarding antibiotics and your wishes regarding artificial nutrition and hydration. So there are lots of different stages and things that can be offered to you at different times. And it's difficult because none of us can really know ahead of time what the decisions are going to be and what we're going to have to face. But having these conversations and thinking about some situations may help you and help your proxy or power of attorney understand what your wishes would be.
Thanks.
You had a question?
Yeah, quick one. I think a lot of people are concerned not maybe so much about the death, but as the process thereof, and they don't want pain. And I understand that there are some things that cannot be touched by our present medications that we have. Is this true, Myrle?
The question was that the concern about the process while someone's health is declining and the fear of pain. I would say that there is usually something we can do for pain. Occasionally, it may be difficult to completely eradicate it, but we can typically do a lot more, and that's one of the hats I'm wearing in my new life.
Right. What about illegal drugs like heroin? Are you not allowed to use those anymore? Or ever? I know in England they can, and I didn't know that.
Yeah, I'm not allowed to use heroin,
Yeah.
Personally or
No.
prescribing.
But there are some things that would work perhaps better that we are legally not allowed to use, even in the medical field.
Let me go for this one. So, the question is, are there things available in other areas of the world that we're not allowed to use here for whatever regulatory reason? And I think what you're referring to is the Brompton's cocktail, which was an elixir that was initially used in England that had heroin and cocaine and camphor and a whole bunch of other stuff in it, and so it made people feel pretty good. So, but the point was that when they really looked at it critically, did it have any advantages over what we can use legally? And the answer is no. So that's really why it was never even brought forward. So it really has been evaluated. Now there are in my experience there have been maybe the last 25 years maybe 2 patients who have had a very difficult time relieving their pain, and they've been very unusual cases. The vast majority of patients respond very well to the usual combination of things that we use, which usually includes a narcotic, a benzodiazepine, oxygen, sometimes medications like Neurontin. And there are even more kind of invasive procedures that we can use for pain control. Things like epidural catheters, or in rare instances, something called a dorsal rhizotomy that I've only had to resort to once or twice, where you actually cut part of the spinal cord that is involved in sensation. So, so there are many ways to control pain, rather than just kind of what you get at the drugstore. So, so the fear of dying in pain is I think misplaced. Okay.
I think what we're talking about here is terminal sedation.
Yes.
Is that, you know,
Yes.
how available is that?
Sure. So we can, I think, talk a little bit about that too. So so terminal sedation is a condition where you know, someone is clearly dying, they're in discomfort, and giving the pain medication that they require may shorten their life. And that is it's okay, it's done all the time. It is not euthanasia. It is it's using something called the principle of double effect, okay, as far as the ethical construct is concerned. And the idea there is that if you have, it kind of goes back to these curves here again, so you have an intervention that is a benefit that also has detriment associated with it. And you have to decide, you know, what is the greater good. And most people think that the greater good is relieving pain and discomfort. So you do what you need to do to relieve pain and discomfort. If one of those side effects is shortening someone's life by a few hours or a few days, then that's an acceptable compromise. Okay, so that's just what happens. So go ahead. Yes.
I'd like to go back to the title of this discussion, which is Tell Me the Truth, Doc. Now, apparently you two would be very open with your patients. What do you think most doctors do today? Do they really level with the patient?
I think it's hard to know. You know, what the question is, do most docs really kind of level with their patients? And the answer to that, I think, is very difficult because we're all human beings and we all carry with us, to a greater or lesser degree, what our own personal biases are. And unless you really pay attention to taking your own personal biases out of it, it becomes very easy to go down the rabbit hole and make recommendations that are based on your personal viewpoints and not really what the patient needs or wants. Sometimes that gets back to the, gee, we're having this conversation in 12.5 minutes and I don't really have time to go into all this today. So you tend to truncate the conversations, which isn't really the right thing to do. But it's it's a difficult problem. The other problem is, what is truth? Okay, truth is probabilities. It's not black or white. And what's true for one person in exactly the same situation is not the truth for somebody else, because we all see situations through our own filter, and what's true for one is not true for another. So it's so I don't know how to answer that. I mean, I don't know what the truth is. I know how to tell you different aspects in which you can look at what your truth might be, but I can't tell you what the truth is.
Some ways that we can help as families or individuals to help our doctors tell us the truth have been stated. One would be bring an advocate. Another would be to know our own values and goals. And I imagine a third would be a receptivity to hear, to really listen to the options. Are there other ways that you find with your own patients that sharing the truth is made easier? Any other ways we can cooperate in setting a field where truth can be spoken?
Yeah, I think the question is, what are the different ways that where we can get to the truth for the individual, and I think we have touched on a couple of them: bringing a family member, thinking about it ahead of time, actually writing down what your questions are and bringing those in with you are really helpful, because that allows you to be focused. It allows you to write down the answers so that you can really kind of evaluate it going forward. The other helpful thing that I find is that when we have this kind of conversation, I very rarely, if ever, ask somebody to make a decision then. Okay, I really encourage people to go home and think about things for the weekend or for the week, and it's really rare where somebody has to make that decision just right then and at that time. So it's really helpful if you kind of touch on it several different times as to what really fits for you. So and it needs to be a decision that's made with me not in the room. Okay, because it just flavors the expectations, So because being a doc is this kind of weird thing somewhere between parent, priest, friend. It's a very odd relationship that you have that really isn't the same as any of the other relationships in your life. So so you have to be cognizant of that.
Thank you.
Okay. Yes.
I'm wondering where you as an oncology doc and the hospice doctor would intersect and what that would look like. How would you be connected to hospice if you are?
Yeah. So the question is how do Myrle and I interact, and the answer is well. I was actually medical director of Boulder County Hospice for about 5 years when I was first in town here from '87 to '92. So I have some experience there also. But
I'm asking mainly, it's like at what point might the connection be made? Is it just when you think someone would be going to hospice? Is that it, and what would there be some follow up as an oncology doc when the person is connected, whether they're connected to palliative care or to hospice care?
Well, if the question is there interaction at the same time between palliative care, hospice, and medical oncology? And the answer is yes. It's really part of that continuum where, for instance, if somebody's being treated for adjuvant therapy for breast cancer and we expect them to be cured, it's probably not appropriate to get palliative care involved. On the other hand, if somebody has metastatic breast cancer and they've had 2 or 3 different lines of therapy, and the chances of responding become less and less, even though the functional status is good, then that's really the optimum time to start thinking about palliative care and really talking about treatment options. So I think a lot of it depends on the individual as to exactly when you call in the other services. So actually, I probably ought to let you talk about that a little bit too.
Sure. Yeah. I'm going to go back to your question about whether docs really level with you. And it is not an easy question to answer. But I just wanted to mention that, doctors try to be optimistic. And I think sometimes that might interfere a little bit with what you're talking about getting the bottom line. But we do try to be optimistic. And that's for most of us anyway, that's just kind of part of our core. So that's something to remember. To answer your question about interacting with docs, it's really up to patients and their doctors. When someone comes on home palliative care or hospice care, we basically just try to join the team that's working with you, and that's usually what we do. And we may make recommendations, but your doctor is still your doctor. We don't replace them by any means. Other questions? Yes.
About the legal documents involved in these discussions. You mentioned POAs, there's living wills, there's this most form.
Mm-hmm.
I mean, do you have to walk in with those in order to have the conversations like you've been talking about with family or friends? Or
You don't have to, but they are useful tools. Oh, question. The question was, what about legal documents? Do you need to have a whole sheaf of these legal documents with you when you have the conversation? I think they're useful tools because they may help you have the conversation, answer questions, and you may be able to complete them at the same time. They may help trigger certain questions you might not deal with otherwise. They are helpful. Put my ER hat back on again. It is helpful if you end up in a place where you can't speak for yourself. To have that have that spelled out, it really helps guide the emergency physician or the critical care specialist who's going to take care of you. And unfortunately, in our healthcare system, it really feels slanted to me that there's so much focus on that, but it has to do with things like concerns about liability. Because for a physician, if they make a judgment without being guided and then someone in that family decides it was the wrong thing, you know, it's a threat to your entire career. Yes?
What do you see as the future of drug? Are you aware of a group called Somalogic and Larry Gold? And genetic imprints for how people respond to different drugs? Because, you know, I'm sure as a physician, like any human walking the earth, there's changes in the way each individual reacts to drugs or reacts to anomalies with their body, for that matter. And so how, you know, what, as an individual, you might say, well, I want this in my, you know, last orders and stuff. But for one, it can change that you're in a state where you can't describe a change that you have. As you're reacting to a pain situation, you might view it differently than you had before you had the pain or before you had that kind of experience. And then if you're unable to communicate that, you know, what can medicine do, really looking forward to see some better ways of actually figuring out how the non-speaking patient can.
Okay, so I think you're asking two questions. You know, one is one question is how far down the road are we with genetic fingerprinting and really kind of being able to figure out an individual's response to any given treatment or intervention, and the second question is, you know, how do you adapt your treatment plan based on the current situation? Am I correct?
Based on, yeah, the...
Okay, so in people that are, so treatment, and whether that be best supportive care and pain medication or chemotherapy or whatever, is really an ongoing process of treatment and evaluation.
Yeah.
So that there's always give and take and there's always interaction, and it's a very fluid kind of a thing. It's not like we make one decision then we stick to it come hell or high water. I mean, you know, it's really about adapting to what the individual's needs are. There are also nonverbal cues that we can use to try to see if somebody's you know, comfortable or not. You know, even if you can't communicate, you can grimace. You can, I mean, you know, there are nonverbal cues that we're all very used to evaluating to really kind of determine whether someone is comfortable or not. So so that's. Although it sounds like it's a challenge, it's actually not as much of a challenge as you might think. I think it's important to speak with your designated decision maker. You know, I mean, we talked about all these different pieces of paper that are flying around out there, and honestly, in my experience, they really aren't that useful. The most useful thing is having a conversation with the person you designate as your decision maker. If you can't, it's only if you can't. It's not that you give up your choice of decision to someone else if you can make your own decisions. But if you can't make those decisions or you're not communicating, to really have a conversation about what kind of things you want to do.
But if you're a fiercely independent person, that's really hard. I wouldn't want to put that decision on anyone else.
Okay.
You know?
So your best option then is to really spell things out as much as possible. So and that's what those forms are for. So. You know, so the second part of that question is, you know, how far down the road are we to really figuring out, you know, individual variations and responses to things? The answer is not as far as you'd think. You know, I mean, there's promise out there. There is, but the more we know about the genome, for instance, the more we realize we really don't know about all the interactions and you know, things we used to think in the genome were just junk or taking up space really aren't, you know, and there's genes that are affected by the non-gene components. We're really technologically at a point now where you can sequence the entire human genome in a day for $1,000. Okay, and 15 years ago, that was a 10-year project that cost $10 billion. Okay, so so the amount of information that we're able to obtain, at this point is overwhelming. The next question is, what do you do with it? Okay, and how do you make that information intelligible to somebody who's going to try to make a decision? And this comes down to the fact that cancer specifically is really not one or two diseases. We talk about it like it's a disease, but it's really tens of thousands of different minor variations, and it's really kind of pure fantasy to think that one particular intervention would fix everything. So it's like, one diet manipulation or one drug or one thing you do or one thing you don't do is really going to fix the whole problem, because it's just not that way. It's just much too complex. So it's kind of like the I don't know if you ever remember the on the midway in the circus, they have those machines where you put a quarter in the top and there's a bunch of little rakes and things, and and there's quarters in all kinds of different and you're hoping that it's going to push one out the bottom. Okay, like the body and the immune system is a lot like that. Okay, so it's like you try to put a couple of quarters in the top and you're hoping for something good to come out of the bottom. All right, but being able to predict that is really hard. So anyway, yes.
I have a question about when someone doesn't want to know certain aspects. Mm-hmm. And it's my understanding that in New York and California there are some laws that require the doctors to give information. And I think the American Oncology Society has this booklet out now about what training the docs about what should be told to the patient.
Sure.
But are those laws, and does that book make an exception when a patient says, okay, you tell me I'm terminal, I don't want you to tell me how long I have because I want to go with optimism?
Sure. Yeah. So the question is, how much do I have to actually tell somebody if they don't want to know it? And the answer is, I don't have to tell them much if they don't want to know it. So at least that's my understanding in Colorado. Nobody's told me any different. So, in fact, last week I had a woman who has recurrent breast cancer. She's 40, and she said specifically, "I want you to give all the news to my husband, and he's going to tell me." Okay, we can certainly do that. So whenever she comes in for a visit, the day before, I give her husband a call and say, "This is what the findings are, and this is what we're going to talk about." And then he does whatever he does before she comes in, and then she's ready to have an intelligent conversation about it. But she doesn't want to find out in the exam room.
That's
Okay.
cool.
So she wants to find out ahead of time from somebody that she really knows.
Yeah.
So.
I just had one other thought that I wanted to mention, and I can't remember, Kim, if you mentioned this or not, but about having these conversations in general. I think one of the challenging things is that we think our docs, it'll be somehow it'll be on the schedule to happen. And sometimes that's true, I think, especially in oncology. Less often maybe in other specialties. Your cardiologist may not necessarily think about it in those terms. So one of the issues is that patients expect doctors to bring it up, and on the other hand, doctors often expect patients to bring it up. So everybody waits for the other party, and so it doesn't happen. So I guess just as a parting thought, one of my words of advice would be, be sure to ask questions and have these conversations and get them started. Yes.
Hi. I'd like to come back to what you said earlier about when you have these conversations, you like to ask open-ended questions and then let the patient respond. When we're having conversations with other family members, what are those open-ended questions that would be most helpful for us to be asking?
Question was, I made a reference earlier to open-ended questions, and I believe the question is how to have these conversations with family members, what kind of questions to ask. Let me think about that. One way to have conversations about this with family members is as you see a situation. So say you have a friend or you see a situation where someone else is having health problems, you can talk about it. You can say, you know, I've been thinking about so-and-so and what they're dealing with or going through. And then use that as a hypothetical. You know, if I was in that situation, I think this is how I would feel about it. Just to get the conversation going. Does that help?
Mm-hmm. But I guess to follow up on that, you know, are there certain questions that would be helpful for you to know and for us to know? I mean, should we be asking about, I mean, I'm not sure. I mean, I know some of this. You know, do you want to have, what kind of care do you want to have at the end? Do you want to have life support? I mean,
the first question I usually ask is, what is your understanding of your health right now? Because people have received a lot of information from other people, doctors, etc., but it's important to understand how much they've actually heard and what they understood from what they heard. Another question, oh, I think it just left my head. Another question is to think about is, how do you feel, what's happened in your health over the past year? How have things changed over the past year? And try to understand what that might mean. So that's another thing to think about.
That's a Kim question, really.
That's a Kim question? Does Kim have an answer? Questions, ways to have this conversation with your family, questions to ask each other.
I would start with what you said. I would ask them.
Come on up. You can say woof again.
You caught me mid-strawberry. I also want to ask Dr. Sitarik this because it's very individual. Like Vicki said, some people don't want to hear it at all, and something's coming up pretty quickly. So to just explore with them, we do a lot of work with advance directives, and really you can ask them medical questions like, what have you seen going on with your body? But you can also open it up by asking them about their values. You know, what's the most important to you right now? Is it being healthy? I mean, is it being active and moving around? What's the most important? Because that'll give you some idea of how they want to be without them having to answer medical questions directly. And you're standing up, so I have.
Yeah. So one of the entrees that I frequently use is, what are you doing with your day? Okay. You know, how functional are you? It's like, yeah, what happens, you know, when you get up in the morning? What, you know, do you get out of bed? When do you get dressed? What, do you take a nap in the middle of the afternoon? Can you get out and go to the grocery store? You know, and if you get answers to those questions that really seem like somebody's functional status is poor, then you know, you kind of segue into how are things going with therapy for you? What, you know, how are the side effects impacting your life? And then it starts to be, well, you know, it doesn't sound like this is really working out for you. And what are your goals, and what are you trying to accomplish? And when you ask those questions, the goals are surprising sometimes. You know, so, you know, I've had people tell me everything from, Doc, if I can't climb 14ers, I'm done. I'm done. Honestly, I mean, it's like, I don't want any more therapy. If I can't climb a 14er, I'm not really interested in living anymore. And then on the other end of the spectrum is, you know, Doc, as long as I can watch TV, I'm good. You know, I'm not in pain and I'm watching TV. Oprah's good. I like it. You know? So, and you know, and most people are somewhere in between, obviously. But you know, so anyway, sir.
I filled out the forms: medical, durable, power of attorney, and living will. And then the designated person and I lived together. My 3 sisters, I have no brothers, came to visit one time, and I just simply said, I have made Molly Wine my designated person, but I need to talk with you about what I've told her. I want to hear from you any objections you have, any thoughts you have. And I used those forms as a springboard. And then I said, you know, now is the time to have the argument, not when I'm or a final path, and while I was trying to make the decisions. And so we had the conversation, and then I told them, think about it, and if you have second thoughts, come back. So I gave them the opportunity.
And I think that, so that's a wonderful thing, because the question I think is, or the comment was, what happens when you designate someone as your caregiver who isn't necessarily a direct family member, who and there may be some potential conflict, between the various folks at a critical time, which honestly never brings out the best in people. Okay, it's and I can't tell you how many times we have this. There's somebody who has been distant from the family 30 years. All of a sudden hears that Aunt Betty is not doing particularly well, and is going to come in and save the day. Okay, because everybody who's taking care of you has no idea what they're talking about, but I do, because I'm guilty of not being there previously. Okay, so so that's a scenario that happens not infrequently. So the more conversations you can have ahead of time, the better, especially if it's a situation where it's a non-family member who's going to be making the decisions. So, yeah, go ahead.
I have a problem with people being told you have maybe 2 months to live.
Mm-hmm.
And people live within this time frame, and maybe they're going to live for another 6 months.
Mm-hmm.
And in the meantime, the person, the whole family, they are going crazy with these 2 months.
Sure.
Why can't doctors just say, you have a limited amount of
time? People ask me that question all the time. What the question is, Doc, I have 2 months to live. It's been 2 months and a week. What's up? So it happens. The way I try to say it is, there's a better than even chance that you'll live, a certain number of months based on my experience in people in similar situations. I love to be wrong about that, but that's just my best guess, and that's why you're coming to me as a consultant, to give me, so that I can give you my best guess. So. I have a patient in my practice who was treated elsewhere. She was diagnosed with a uterine cancer. She had metastatic disease at the time of diagnosis, and she was told that she has 6 months to live. And that was about 6 years ago. The problem with that was that she said, my docs told me I had 6 months to live, so I sold all of my possessions, okay, and gave everything away that I owned because I was going to die. Okay, it didn't happen. And I see her every 3 or 4 months, and she's really has no evidence of metastatic disease at this point. For whatever reason, she was one of those people on the tail end of the curve here that I can't explain why. But but we all have experience like that, where there's some people who just don't fit the median, the median on the curve here. However, most people do. So you really have to talk about life expectancy in terms of probabilities, and that's hard sometimes. So, Myrle?
Hope for the best and plan for the worst.
Yeah.
We have a great study, that shows that physicians tend to prognosticate 5.3 times more than people have. So that rather than being told you overestimate, so that rather than having 2 months, they will probably tell you you have a lot more time than you think. And some of that's the lack of skill if you're not really trained in this. And some of it may be the fear of the physician to talk. But so what happens is they feel like they're doing people a favor by giving them a lot more. After running grief groups for 20 years, when people come in and say, I didn't have a chance to get ready, and we didn't know what to do, and we're angry that we were told, oftentimes what really happens if you don't have a skilled physician is a lot worse than what you're thinking is going to happen. And what we know about end-of-life care is the worst thing you have to deal with is surprises. Surprises, the fewer you can cut out, the better your experience. Because the goal of end-of-life care is not to make it a medical event. It's to attend to the medical pieces, but not to have it be a medical event. Who hasn't spoken? You.
Would you clarify this family decision-making with the doctor and the hospital? As I understand it, I'm not clear on it. If you have an internist, you're going to have a hospitalist that doesn't know you at all. If you have a specialist, is the specialist like Dr. Sitarik or a cardiologist, are they that are treating you, are they in on the decision-making? And if it's not, if you're put in with pneumonia and you're seeing a hospitalist, is that this person you've never seen before in your life? Is that the person that's sitting in with you with this decision-making?
So the question is, in a hospital situation, when you have a number of different physicians, some with specialties, perhaps a hospitalist that doesn't even know you, who and how makes the decision process?
This decision conference.
Yeah, the decision conference. Who comes together to make that? Which physicians, what other part of the medical team? You've been in the hospital, would you?
It all depends.
Okay, and let me reiterate, this is why Dr. Sitarik is saying those conversations with your family ahead of time are the most important things you can have, because then you have natural advocates who are actually helping you make that choice.
But you still need a doctor's input, because we're not doctors.
You know, you still need a doctor's input, is what she said. I think the problem often is that you're going to get way too much input from way too many people.
Yeah, who makes a decision in the hospital, or who helps you make the decisions in the hospital? I mean, it's a bad problem. You know, I mean, there's no question about that. There's no way to sugarcoat it. The way that medical practice has evolved is that, you know, unfortunately, medical personnel resources are not as we don't have as much time as we used to. There aren't as many people to do the work, so we have to work in as efficient a manner as possible. And the way that's evolved is hospital work is very inefficient for somebody in private practice, unfortunately. So, you know, most institutions have really gone to this hospitalist concept, and I think there's a couple of ways to minimize the impact. I mean, one of the things that we do in our practice is that, and we can only do this because we're big enough to do it, we designate one of our oncologists as the hospital doc at any given time. So although it may not be your primary oncologist who's taking care of you in the hospital, it's one of my partners. Who has access to all of your records, who may be calling me up on a daily basis to say this is what's happening with you know, this patient, and we're going to talk about, you know, options, and do you think those are reasonable options or not? You know, so that's kind of the way we minimize the impact of that. Not all specialists work that way, unfortunately. So the best thing you can do is really, you know, make your wishes known ahead of time. If you are being taken care of by somebody you've never seen before, ask them to give your doc a call, and they'll do that. You know, so so that there's additional input, or, you know, ask that your doc give you a call on the phone, because they'll do that too. So it's really all about trying to establish, you know, adequate communication, given whatever the situation might be. Sir?
So, one of the purposes, or a main purpose, of signing up for hospice is to stay out of the hospital and not have to confront those issues. So, for hospice patients to wind up in the hospital, I would think is pretty unusual. Would you agree?
The question is, do patients on hospice, do they end up in the hospital, and why does that happen, I think? Is that close?
Yeah, I mean, isn't it kind of unusual for a hospice patient to wind up in the hospital?
Well, it's unfortunate. Does it happen often? Not often, but does it happen? The answer is yes. And in my experience, it happens when a family member panics and calls 911. Okay, so that's how people end up in the hospital. So, actually, probably that one.
Yeah, if a hospice patient is having trouble, typically hospice will try to troubleshoot that, send someone to the house, evaluate what's going on. Sometimes it's when a family member panics. Other times it's when something unexpected happens. So someone may be on hospice because of their heart disease, and then they trip and fall and break a leg. And they're somebody who's up and walking, and then you have to figure out what to do about the broken bone. You know, so I mean, sometimes there are some surprises there. But usually what we try to do is work, what hospice tries to do is work with the patient and family and, you know, help decide what to do with this new development. Yes?
I have two questions, a statistical question and an intake question. 4 or 5 years ago, Darla told me that in your hospice, 33 to 45% of your patients were in only for 4 to 7 days. And somebody referenced earlier that a lot of people don't come into hospice quick enough. So I'm wondering about the trajectory of that stat. Is it the same? Has it increased? Has it decreased?
I think it's probably still about the same.
Yeah, it's up and down, but yes.
Okay, thank you. The second question has to do with procedure, intake procedure. And I don't want to give the whole long story with my dad, but suffice it to say, he was in a hospital for what we believed was a curative treatment path. Due to non-disclosure, the family had to abandon that path, and he was lucid when he abandoned it with our concurrence. That's me, the adult children. He was lucid for hospice intake, but in retrospect, he shouldn't have been brought into hospice at that time. But the intake process did not include any questioning about even that brief medical history. In other words, to answer the question, why are you coming into hospice now? Should you really be coming into hospice now? So I'm curious to know, in hospice intake here, do you guys just accept the fact that a hospice recommendation or consult has been asked for or ordered, or do you actually, as part of the intake, ask some probing questions to determine if it is, in fact is fully desired and appropriate?
So the question is about hospice intake. Situations can vary. Sometimes people will call us and they want to just learn what is hospice and when is it appropriate, because they're planning ahead. That's kind of rare. That's kind of rare. When a referral is made, typically there have to be 2 physicians who agree that the patient's appropriate. And then if they're requesting hospice directly, it's usually a hospice admission nurse who would be taking the history, and those questions should be asked to find out why hospice is being thought of at this time, you know, what's happened to prompt this. One of the things I try to do is see as many hospice patients as I can when they come on, to help do exactly what you're talking about, and look at the medical side of it, and, you know, review medications and do that. Unfortunately, because a lot of people come to us late, hospice patients don't always meet a hospice physician. Does that help?
Yeah.
Okay.
Anyway, thank you.
We're going to wrap up here in a second, but before we do, what I'd like you to do is speak a little bit to the palliative care consults, because that's kind of also what you're talking about, is how do we talk to people about whether they're appropriate for hospice, and the trajectory now often is about how are they appropriate for palliative care.
Could you ask that gentleman to ask his question? He's had his hand up almost. That gentleman.
Can I ask a question?
Sure, go ahead.
This goes back to what we were talking about, palliative use of drugs in the end stage of projected survival. I just wonder what kind of research might be being done on keeping your mind clear.
Keeping your mind what?
Keeping lucidity, or keeping your mind clear as long as possible. You know, using drugs which don't have that side effect of really confusing you, really lessening your awareness of what's going on.
So the question is about how we try to keep what we can do to keep our minds clear if we're receiving palliative treatment. Oh, okay. But are you talking about like pain medications, because those cloud consciousness?
Sure. So the question is, how much do we strive to keep patients lucid as long as possible and still relieve pain and suffering. Is that correct, sir?
It is. I'm wondering what research is being done on it, if any, and what the medical profession is.
You know,
Tim Leary.
Well, let me talk about what we shoot for as far as pain control is concerned, perhaps, because all medications have side effects, and if you push them too far, then they have more side effects than you really want. So the idea with pain relief is not to relieve pain completely. Okay, that's a fallacy, because if you do that, then you make people comatose. So that's really not what the aim is. The aim is to bring that pain level down to, on a scale of 1 to 10, maybe a 2, or maybe a 3, in my opinion. But I think Myrle wants to say something.
So one of the things we do when we're treating pain is find out from the person who's experiencing the pain. You try to get them to rate their pain, and then it's very important to say, what do you need? What pain level is acceptable for you? Because some people, it's different. It's very different, and I can be surprised by this sometimes, but it helps me understand what the goal is for that individual, because they need to be making that call.
Yeah, and I absolutely agree with that. I mean, I use the example of a 2 or a 3 because I think that's what most people will commonly say, but there are some people that wanted it a 0. And are willing to accept a decrease in their sensorium. There are some people who are really good at like a 5 or 6, and that's really where they want to be, because they just want to kind of take the edge off, but they really want to be as mentally intact as possible. So it's really, I think, very individually variable. So, sir.
So I'm wandering around in a fugue-like state a lot of the time.
Yeah.
I mean, I need my wife to be within grasp. Otherwise, I'm liable to get lost. So, and it's not because I'm taking pain medication. It's because of accumulated chemotherapy probably has befogged my mind. What can the medical profession do for me to clear up my mind, to make me lucid? To enable me to have a coherent conversation.
Well, the question is, how can we treat chemo brain?
He had a transplant, so
okay.
The amount of chemo was huge.
Was huge, right? So there's definitely some mental decrement that goes along with that, and and it's also, there's been some research done on breast cancer. We've tried a variety of things over the years. With a greater or lesser degree of satisfaction. Modafinil is one of the medications that we'll sometimes use. It's a relative of Ritalin. It's not quite the same, but and some people respond well, but not everybody does. So we don't have a great fix for that. At least I don't. I don't know if you do, but it's a problem. It's a problem. So.
I'm sorry, we have to close. You could do this kind of conversation for a couple hours more, couldn't we?
Yes.
So this is a great group. People are so participatory, and if you want us to come back, let us know. I want to say a couple of things that are coming up that we're doing, because I think you might be interested in them. We're sponsoring an end-of-life and ethics conference, so it's going to be a couple hours of people talking about the ethics of end-of-life, like Dr. Sitarik brought up. It's a fascinating subject, and it's also really important, especially if you are in the medical system. We're also going to be doing a workshop coming up on advanced directives. It's a half a day. We talk a lot about how you fill those forms out. What about the conversations? And how do you look at your values to figure out what you really want, rather than guessing at medical decisions. No charge, half a day, any of these things, and there's more in here. Pick up one of these in the back of the room if you're interested. There's a phone number on there. This is a 2-page colored brochure handout with all of the things that we're doing coming up. Okay? Thank you very much for coming.
Thank you very much. Thank you. Just one final word. May 12th is our next meeting, so mark your calendars. You'll be getting notified, and certainly feel free to bring a friend or two.